Hello there, this is Dr. Karthikeyan again. We are talking about blood sampling in newborns, the ways and means and ifs and buts. Very important topic, I already told you. This is very important, and this is the part 4 and the concluding part of this interesting topic, blood sampling in newborn, right? We are talking about umbilical vessels for sampling, an essential requisite, especially extreme preterm babies and also in bigger babies. It's not that the bigger babies are without problem. Both extreme, very big babies with mecanomaceration syndrome, persistent pulmonary hypertension, they go for ECMO. Who goes for ECMO? Big mature babies with mecanomaceration syndrome. Tiny tots pulmonary vasculature is still not very resistant. Is a term baby. So those are also very sick babies. Sick babies can be either extremely mature, those very big who aspirate this meconium and go for PPH. All right, let's proceed here now. Next slide. The synopsis for the presentations already finished. We had part 1, part 2 and part 3. The videos were there already loaded in my channel. Please have a look at those videos. Please subscribe, look at this and new the importance of blood investigations, the need of micro containers and auto analyzers. This was the introducing topic. What's the importance of blood investigation? It's finished, already uploaded. Capillary blood sampling and heel pricks technique, the easiest way of obtaining sample without invasion, minimal invasive capillary prick. And venous blood sampling, as veins are many, and veins can be of many caliber also. Caliber also varies. Some can be used for cannulation, some can be used for sampling. Correct. So we are there. We have finished that. And also peripheral arteries also. There was a concept of cannula vessel diameter or size ratio, which is in extremely mature. This will favor the central vein access or central arterial access. Understand? In the sub 500 especially, peripheral cannulation, because of cannula size, the vessel diameter discrepancy may not be feasible at all at this point of time. Technology may advance, we might advance, it will advance in future. Now, right, so the central access sampling is this umbilical artery and venous blood sampling. I say umbilical vein is easily visible, accessible at all ages, of the newborn or the gestation, because there's a connecting stock between the mother and the baby. A fetus is a single cord, umbilical cord is the life is the umbilical cord connection between the mother and the fetus, and so we should follow the nature's principle. This next slide. This where we discussed this accepted methods of blood extraction. That's interesting. Next. Umbilical vessels are easily accessible in the newborn infant, particularly the very small tiny dots. Units less than 1000 gram birth weight and extremely mature gestation need UAC as the cannula. Blood vessel ratio may preclude even consideration of peripheral artery cannulation as the technology stands now. I say technology advances. It's a nanotechnology. Well, there might be solutions to this also. Correct. Now, I told you one is in larger infants, significant respiratory distress are often requiring frequent monitoring and umbilical blood vessel sampling. Next. This is this view of umbilical cord. When you cut, we have two arteries and vein. Identification of arteries and veins very important. A vein, by its nature, thin walled, less muscular, and it cannot go for spasm or contraction because it's less muscular, wide lumen, and it's easily visible. The blood doesn't squeeze out of the vein, it drips, it doesn't squeeze. Pressure is low pressure, so it's umbilical vein. This very crucial to identify these three vessels, very important. And an umbilical artery is thick lumen, muscular, and it shrinks because muscle is high, and it can go for spasm also. It has got muscular strength. So by common sense logic, cannulation of umbilical artery will be a more challenging task than umbilical vein. But arteries are at pressure level, and so to monitor the invasive blood pressure and also for uninterrupted EC sampling, UAC still is needed in many instances, especially when you require blood gases, accurate blood gases to make clinical decisions. The next slide.
The Sarawak General Hospital Pediatric Department brings you a step-by-step guide to UAC-UVC insertion. Firstly, start by preparing the UAC-UVC set. Then be sure to observe proper technique of scrubbing and gowning. Choose the correct size for your UAC and UVC. Then clean the umbilicus and its surrounding areas and proceed to drape to maintain a sterile feel. Cut the umbilicus horizontally, leaving behind a 1 to 2 cm stump. You'll then be able to visualize the two arteries and the vein. Next, use the probe to dilate the artery and proceed to insert the catheter to the desired distance. Ensure the correct cannulation of the umbilical arteries by observing the visible arterial pulsation as well as the bright red blood withdrawn into the syringe. Proceed to check the circulation of both legs to observe any signs of arterial occlusion. We then proceed with the umbilical vein catheterization. Identify the umbilical vein and then proceed to use the probe to dilate the vessel. Then insert the umbilical vein catheter to the desired length. To prevent the UAC or UVC from being dislodged, secure it in place by using the suture. Plaster the UAC and UVC in place and clear all sharps and clinical waste accordingly. Connect the UAC to the probe and observe the waveform. Finally, perform a chest and abdominal X-ray to confirm the position of the UAC and UVC.
Next, having an arterial line is a key step. We ensure correct positioning of the artery. Get an arterial line, peripheral or central. but do remember to take samples following due diligence. So while ensure patient safety, ensure that you are also safe. You do not suffer from any physical or financial damage. Here, spell check. Spell check is there. So there are in-loop sampling techniques, safe sampling techniques are available. Follow them according to the unit protocols, right?
Safeset is ICU Medical's closed, needleless blood sampling system that allows clinicians access to the patient's blood without exposing it to the outside non-sterile environment or exposing the clinician to bloodborne pathogens. The Safeset design incorporates an inline reservoir and novel flushing technology that complements the performance of the Transpac monitoring systems when frequent blood sampling is required. Complete needle-free access to the patient's blood is provided through the use of the novel swabbable valve. This valve utilizes key design features that eliminate some of the additional steps required during the priming and flushing process when using the traditional swabbable valve for blood sampling. To access the patient's blood for sampling, first, turn the handle on the swabbable valve so that it is oriented opposite to the valve. Then aspirate the desired clearing volume into the Safeset inline reservoir. Turn the one-way stopcock at the tip of the Safeset reservoir to the off position. Swab the valve from which the sample will be obtained in accordance with your facility's protocol, and access with any luer locking or luer tipped blood collection device. Withdraw the undiluted blood sample through the swabbable valve. Before removing the access device, turn the handle on the swabbable valve so that it is oriented towards the valve. It may also be oriented towards the patient connection. Remove the access device from the valve. Once the sample has been obtained, turn the handle on the swabbable valve so it is oriented opposite the valve, and reinfuse the clearing volume contained in the Safeset reservoir by slowly pressing the plunger until the locking clips lock onto the reservoir slots on the reservoir barrel. Then activate the flush device at the transducer until the line is clear of any residual blood. When the procedure is complete, swab the valve again and turn the handle so that it is oriented towards the valve. The Safeset with the new swabbable valve is the simplest way to obtain a clean blood sample while eliminating blood waste and exposure.
Position of UAC and avoidance of thromboembolic complications. Position of UAC, high position is about T10 and between T6 to T9. Cochrane review recommends high is preferable to avoid complications because this is above all the major branches of descending aorta. And I said UAC needs to be kept patent, any arterial line in fact, and free flowing without standstill thrombotic complications by infusing heparin saline continuously. The concentration of heparin saline varies from 0.5 unit per ml to 2 units per ml per unit policy. Correct? So heparin saline is an essential, unavoidable part of maintaining patency of an arterial line without complications. The early signs of thrombotic complications, excellent and bedside nursing care is very important to avoid complications of any arterial line, including UAC. Thrombotic complications are common, yes, because the size of the vessels is like that, and neonates, any blocks or very easily can happen because of even small tiny blood clot. So why common? Because miniature vessels, the prothrombotic status of the sick neonates, dehydration. These neonates are in a state where the fluid imbalance and the fluid loss and gain has to be balanced by the neonatologist. Cardiac output low, polycythemia, sepsis, and so need for continuous vigilant neonatal care. And what is vigilant nursing? Continuous heparinase saline infusion. Saline infusion should go without air bubble. Look out for blanching discoloration in the areas of blood supply distribution of this artery which has been cannulated. If it is UAC, it's the whole of the upper limb, the buttocks, and lower part of the abdomen as well. And scrotum, covered part. Correct? So here vulva, scrotum, gluteal region, lower limbs, and the toes. Information and immediate intervention on notice of any of the warning signs, any of blanching, discoloration, earliest time has to be acted upon and taken very seriously, so that because loss of a body part very common through the traumatic complications, so it should be noticed and documented and acted upon medico legal. So the actions recommended, this is a reiterate because it's not that you just obtain sample, but not at the cost of loss of limb or loss of life. You save a life with loss of limb, still you are liable unless you have taken the due diligence of care. Correct? So what are the actions recommended? You should attempt reversal of vasospasm, which is this logic is not as a tried is warming of the contralateral limb. This is a response, sympathetic response, a reflex, which will cause warming of the contralateral limb will cause vasodilatation and relieve the spasm. Arterial line undergoes because of the muscular reactions. In case of peripheral artery line, loosen the tight bandages, expose and see for yourself the situation. That's important when you see that. Many times IV dextran bolus will improve the systemic blood flow, liquid, a little bit more free flow, so that small tiny clots will vanish away. Removal of the catheter in question, if 15 minutes of attempting as about doesn't work, you have to remove the catheter. When 15 minutes can give a salvaging chance. The salvage time recommended as per the guideline state is only 15 minutes. Remember that? And it's not that you lose the catheter and lose hope, because babies need sampling. You will lose the life if you don't do it. So get another catheter in some other site. Correct? Sampling is required. You have to get the life going on. But do the due diligence. You should be vigilant and document in the car that you are following that, you are observing. I request what I observe this, I observe everything was clear. At this point, I notice it 15 minutes, we follow the rules, we remove and get on the line. Explain to the patient that this is expected and we follow the due diligence. Correct? Next. So in case your action is important, what actions right now which is available is topical 2% nitroglycerin ointment at 4 millimeter per kilo strip, 4 millimeter per kilo along the vascular territory line. In question, reverse the vessel and restores the perfusion within an hour of application. Vasodilatation. Hydroid ointment proved to be useful. I have personally used this in a peripheral artery inadvertent accidental distilling gangrene case. It reversed in total. There are case reports of successful use of hydroid ointment. Aggressive management of heparin infusion or fibrinolytic agents. If you seriously anticipate a major loss of a vascular territory, such as a limb loss equal to amputation, that you have to be very aggressive, salvage the limb. Correct? So it's heparin infusion fibrinolytic agents. Depending on the clinical status, very important. It should not cause IVH also. So the clinics have a very balanced view, assess all the risk, and it is a decision by the highest level of medical authority of care. In UAE, it's consultant or your board of consultants. That's it. And with those words, we conclude this blood sampling presentation. It's the end of the series of interesting videos, presentations on blood sampling of the newborns. This is part 4, maintaining and following due diligence in central venous access. Please subscribe to my channel, New G Heal a Baby's YouTube. Here's the link. With a big thank you, I close this session. An important topic was discussed: blood sampling of newborns, the tiny dots, sub 500 babies, access, sampling, easy way, medium risk, highest risk, essential things. Following due diligence and be vigilant to avoid complications. With that words, I say a big thank you. Thank you for observing. Please subscribe to my channel. This is Dr. Karthikeyan, consultant neonatologist in Dubai. Thank you.